Okay, so the next PowerPoint that we're going to go through is about sleep disorders and treatment. So this is going to cover 3 dot points. Now again, I've highlighted the sections that I would like you to fill in into your notes, but there's not that much content that you'll need to write in for this one. So we're looking at dot points 10, 11 and 12. So our first dot point is the distinction between dysomnias, so sleep onset insomnia, and parasomnias, including sleepwalking, with a reference to the effects on the person's sleep-wake cycle. So we are looking at a distinction, so we would like comparisons. In terms of insomnia and sleepwalking, you just kind of need to know some facts about them. We are talking about changes in the person's sleep-wake cycle and susceptibility to experiencing a circadian phase disorder, which is a type of dysomnia, including sleep-wake shift in adolescence, shift work, and jet lag. So this dot point is all about mismatches in environmental cues and the sleep-wake cycle and how that can lead to sleep deprivation. And then our last dot point is interventions to treat sleep disorders. So we're talking about CBT again with reference to specifically insomnia. And we're also looking at bright light therapy with reference to circadian phase disorders. So I guess the first thing that you can do is have a go at this Epworth Sleepiness Scale. So this will indicate how likely it is that you will fall asleep in the middle of these situations. Now, if you have a higher chance of falling asleep in these particular situations, so sitting and reading, watching television, so on and so forth, it might mean that you probably have some kind of sleep deprivation, which might be indicative of some kind of sleep disorder. Okay, so what is a sleep disturbance? So this is a sleep-related problem that disrupts an individual's normal sleep-wake cycle, including problems with sleep onset, waking from sleep, and abnormal behavior occurring during sleep. So what this means is you can't go to sleep. It might mean that you might wake up from sleep and you can't go back to sleep, or you just keep waking up from sleep. So people who have sleep apnea, so snoring, they wake up a lot of the times during the night, or it might be indicative of abnormal behavior that occurs during sleep, so like sleepwalking. A sleep disorder is when a sleep disturbance regularly disrupts sleep and causes distress or impairment in everyday functioning. So what we're looking at here is something that is consistently disrupting the normal NREM and REM pattern, okay? To be diagnosed with a sleep disorder, the problem has to be persistent, it has to cause the person significant distress, and it has to interfere with their social or their occupational functioning, okay? So we might, for example, have a sleep disturbance one night, so we might have a nightmare or a night terror, and that might wake us up, and we might have problems getting back to sleep, or we might sleepwalk once in a while. But when that is persistent, it occurs a lot in a long or short space of time and has effects on your life, then that's when we would term it a sleep disorder. We can have primary and we can have secondary sleep disorders. So a primary sleep disorder is a sleep disorder that cannot be attributed to any other condition, like another sleep disorder, a mental disorder, or a medical problem, okay? So like if you have insomnia, we might consider that a primary sleep disorder. A secondary sleep disorder is a prominent sleep problem, but it's a byproduct or it's a result of another condition. So like if you have back pain and therefore you cannot sleep, that would be a secondary sleep disorder. A lot of sleep disorders can be comorbid, so what that means is they occur with another condition, and that's kind of the same as having a mental illness. So you typically don't have like a sleep disorder with something else, so you might have insomnia and you might have anxiety. Or if we're looking at just comorbidity of mental illness, you might have anxiety and depression. So typically these disorders, they don't tend to occur by themselves, but they tend to occur alongside or with other disorders. So the first thing we're going to talk about are parasomnias. So parasomnias are sleep disorders characterized by the occurrence of inappropriate physiological and psychological activity during sleep or sleep to wake transitions. So parasomnias examples are sleepwalking, sleep apnea, which is snoring, teeth grinding, night terrors, night terrors, and sleep talking. So these are things that are inappropriate, and they occur during sleep, and what that can do is that can actually interrupt your normal sleep-wake cycle. So we're actually referring to specific events when you're meant to be asleep. What these do is they disrupt the quality of sleep. The person tends to be unaware of them. So night terrors, you might wake up because you're having them all the time, but you don't necessarily know why you're having them or that you're having them. Sleep apnea wakes you up a lot, but you may not necessarily be aware of the fact that you are waking up a lot. You might just be aware of the fact that you're super tired. And sometimes parasomnias can lead to dysomnias, which is the other type of sleep disorder. So like if we have regular nightmares, it can actually lead to insomnia, which is trouble falling asleep, okay? So these are phenomena that occur when you are asleep, not going into sleep or coming out of sleep, but they are events that occur in sleep that interrupt your sleep-wake cycle. Okay, so our example of a parasomnia is sleepwalking or somnambulism. I just call it sleepwalking. So this is when a sleeping person walks or does routine tasks during deep NREM sleep. This typically occurs in stages 3 and 4 NREM. So of course when we were experiencing delta waves. This tends to occur from up to 15 to 30 minutes, and it generally occurs in the first third of sleep. So think about our hypnograms and think about the proportion of NREM 3 and 4 sleep in the night and consider why it might be the case. Hint, or here's the answer. We only generally have stage 3 and 4 NREM sleep in the first third of the night because, as we know, proportionally, we have higher REM sleep at the end of the night, so we actually don't experience any 3 and 4 NREM. So pretty much about 70% of children sleepwalk and 2% of adults sleepwalk. It's more common in children. And that's actually because they tend to have a high proportion of NREM 3 and 4 because they sleep longer. Elderly people tend not to have very much sleepwalking at all. Why? Because they don't really experience that much 3 and 4 NREM. In terms of the key symptoms, there's like quite a range, and I'll explain all of them to you, but you kind of don't really need to know them. So we tend to have, or those who sleepwalk tend to have a range of mobility and activity during sleep. It does vary in terms of type, complexity, and duration. Movements tend to occur in a confused and clumsy manner, although in calm episodes, they can maintain coordination. Things typically are performed that are routine or well learnt. So for example, opening doors, dressing, cleaning, eating, or packing a bag to go to work. Complex behaviours are rare. So like driving a car can happen, but doesn't necessarily happen that often. There have been some really interesting case studies of the crazy things that people have done when they sleepwalk. My friend Anna, she sleepwalks a lot and she actually eats yogurt in her sleep. And I remember her calling me one time being like, I'm pretty sure someone is coming to my house and stealing my yogurt. And then it turned out she was actually just like eating her yogurt while she was asleep and her boyfriend had caught her, and that's how we know. But there are case studies of people like, driving cars, or they might go to work, they might get on public transport, or they might even find themselves atop large cranes. We may perform, or they may perform, socially inappropriate behaviours, so like urinating in a bin or a cupboard, and sleep talking can also occur within this stage. It tends to end spontaneously if a sleepwalker is left alone, so they normally just go back to bed, and it's pretty difficult to arouse or wake the person during those episodes. Excuse me. Because they are in stage 3 and 4 NREM sleep, so of course that's the deepest stage of sleep. There's little or no awareness during an episode, and so they are typically unresponsive to any attempt to communicate with them, and episodes often are not remembered. Sleepwalkers may be confused and disorientated if they are awakened, and they may not remember any family or friends. There's this big conspiracy theory that you can't awaken a sleepwalker because they might get super dangerous, but that's actually not true at all. So I'm going to send you this PowerPoint, but click on the link and you can read this case study of a guy, a father, and he killed his son. And so he was obviously charged for it. And he was found not guilty because he was actually sleepwalking when he actually killed his own son. So read the article. It's really fascinating, but also like really, really interesting. Sorry, what I mean is really, really scary. Okay, so the causes. Sleepwalking is in a sense idiopathic in so much as we don't quite know what causes sleepwalking really. Like we have an idea, we have theories, but we don't actually 100% know what actually causes it. It tends to be common in children aged between 5 to 12 years old. Why? They tend to have more 3 and 4 NREM sleep because they sleep longer. Tends to happen much less in adults. Why? They have much less NREM 3 and 4 sleep. The triggers tend to include stress, anxiety, and use of medications, and the theory is that it is at least in part hereditary. Why is that? Because in twin studies, we see that if one twin sleepwalks, the other does as well, and there tends to be a family history of sleepwalking. In terms of like the effects of the sleep-wake cycle, pretty much it leads to sleep deprivation. Like that's pretty much what happens. If we're going to kind of like go into more detail, there is a loss of deep sleep, obviously because you sleepwalk or you are more active in NRM 3 and 4 when your body should be regenerating itself. And so there's an interruption to that natural progression of the sleep-wake cycle during the sleep episode. Sleep, therefore, is fragmented, and so you tend to get less than normal numbers of sleep cycles if the episode is prolonged. What that means is that you're obviously sleep deprived, and you may have daytime sleepiness, so you may feel obviously sleepy subsequent to the episode. There's actually no specific treatment because we don't necessarily know what the triggers are, and it's individual for everybody, and we don't necessarily know why it occurs. But there can be basic changes to the person's sleep-wake habits that can improve the quality of sleep during the night, and it might reduce the episodes. So in comparison to parasomnias, dysomnias are sleep disorders that may produce difficulty in initiating or maintaining sleep or the timing of sleep. So what they do is they are characterized by disturbance of normal sleep patterns, including quality, amount, and timing of sleep. So rather than phenomena that occurs during sleep, which might interrupt it, this is actually like trouble going to sleep or actually like going back to sleep. So this can involve explicitly falling asleep, staying asleep, or stopping sleep onset when you're meant to be awake and aware. What this results in is a decline in the quality and the quantity of sleep, and so it results in excessive daytime sleepiness, which of course is your sleep deprivation. Examples are insomnia and circadian rhythm phase disorders. Another example which you don't need to know about is narcolepsy. So our example is sleep onset insomnia. So that's a disorder resulting in a persistent inability to fall asleep at night. So what it means is obviously you just can't go to sleep. So this is a primary sleep disorder. However, it can also be secondary to other sleep disorders. So when it's associated with breathing disorders, it can be secondary. If the insomnia is acute, these symptoms can subside or will subside once the person returns to their normal sleeping pattern. Acute insomnia is often caused by emotional or physical discomfort, and it can be related to a single specific event. So like if you had a breakup, you might have insomnia, or if you've got like a toothache, you might have insomnia. For chronic insomnia, so having insomnia for 6 months or more, the symptoms are far more debilitating, and so what it results in is physical and psychological effects. And so we're talking about that kind of chronic sleep deprivation, which can lead to like mental illness, obesity, diabetes, and all that kind of fun stuff. Insomnia is the most prevalent of all sleep disorders. So it's quite common. About 30% of adults have symptoms of insomnia at some time. 5 to 10% of adults have persistent insomnia disorder. The onset of these symptoms can occur at any time in life, although they tend to be more prevalent amongst older individuals or older adults. There's increased risk for females, the elderly, and new parents for obvious reasons, re the new parents. In terms of the key symptoms, there is a regular failure to fall asleep within about 20 to 30 minutes after intending to go to sleep. There is a complaint of poor sleep quality or quantity, and sleep onset difficulty occurs frequently and persistent despite adequate opportunity to sleep. This would tend to happen at least 3 nights a week for a minimum of 3 months. So in terms of our causes, we obviously have psychological factors, physiological factors, and behavioural factors. So psychological factors are things like anxiety, excitement, cause insomnia. Fear or of insomnia may worsen the problem. So like if you are going to bed, and I think we've spoken about this actually. So if you go to bed and you're like, oh my God, have to be awake in 3 hours, I'm not going to go to sleep, and you start stressing about it, it actually makes the insomnia worse. So you might as well just rest and just close your eyes and chill out, because that's going to make your life a lot easier. Physiological causes include a genetic predisposition, chronic pain or breathing difficulties, restless leg syndrome, delays or reduced melatonin release, and dementia. Behavioural factors include things like caffeine, nicotine, alcohol, shift work, jet lag, and artificial light from phones, which we have spoken about. So we know that when you are on your devices at bedtime, the blue light that is projected from the screen is enough to stop the secretion of melatonin, which of course makes you feel more alert when you should be going to sleep. This has massive effects on the sleep-wake cycle. So this changes the amount, the restfulness, and the timing of sleep. Sleep onset occurs much later than desired, and it tends to be non-restorative, so you actually don't get the restoration that you need. The total sleep time may be less than desired, and this leads to excessive daytime sleepiness. And so what that might actually mean is you can't wake up in the morning, and that will actually delay the sleep onset. And what it can actually do is it can actually disrupt your whole circadian sleep-wake cycle, which means that your body clock is not in sync with your environmental cues, and that can lead to real problems and excessive sleep deprivation. Okay, so how do we treat insomnia specifically? So we use cognitive behavioral therapy for insomnia. So it's actually called CBTI, and you are familiar with this because you did it in mental health. So this is a type of psychotherapy that uses cognitive and behavioral methods to help people change unhelpful or unhealthy thought processes, feelings, and behavior. So it's called CBTI. It focuses on the causes of sleep problems and changing unhelpful behaviors. And it tends to be short-term, usually 8 to 10 sessions. What it does is it focuses on the role of cognition, so thoughts, beliefs, and attitudes, in determining emotions and behavior, and aims to help a person change the way they think about situations, and so their cognitive distortions, to a more balanced and helpful way. What it assists is the individual to address anxiety with sleep difficulty, and learning how to control or eliminate worries and negative thoughts that prevents sleep onset. So in terms of the cognitive components, what they do is they identify faulty or dysfunctional thoughts, and they look at alternative interpretation of what is making the person anxious or causing concern about sleep. So what they might do is they might develop realistic expectations of their sleep and not blame insomnia for all of their daytime impairments. They may not believe that losing night's sleep will bring awful consequences, and not give too much importance to sleep, and to develop some tolerance to the effects of lost sleep. The way they might do this is they might use a sleep diary to record their tiredness, negative thoughts about sleep. They're then provided with accurate information or evidence about sleep, and so they then identify and replace the unhelpful thoughts with ones that are more realistic, like, oh, well, if I get 3 hours of sleep, I'll probably feel pretty shitty tomorrow, but that's okay. I'll still be able to function at work. Not, oh my God, if I only get 3 hours of sleep, the world's going to come to an end. I won't be able to go to work, and my life is over. In terms of the behavior component, what we're looking at is learning theories and principles to treat maladaptive behavior. So we're looking at behaviour that is dysfunctional or interferes with the ability to carry out one's usual activities in an effective way, such as poor sleep habits, and that's something called sleep hygiene, that impact on sleep quality or quantity. What this actually does is it helps individuals to develop good sleep habits and avoid behaviours that actually prevent them from sleeping poorly. There are two strategies that they typically use in CBTI. So we have stimulus control therapy, which encourages clients to use the bed for sleep rather than activities that can stimulate the mind. So rather than using your bed for like eating or doing homework or reading or things like that, what the therapist will do is they'll use classical conditioning and operant conditioning principles to actually strengthen the association between sleep and the bed. So what we're doing is we're strengthening like cues almost. We would also use, or they would always also use sleep hygiene, and that provides information about practices that tend to improve and maintain good sleep and full daytime alertness. So that involves changing basic lifestyle habits such as smoking or drinking too much caffeine that influence the quality and the length of sleep. Okay, so some other examples of dysomnias, although a whole dot point in their own right, are circadian rhythm disorders. These disorders are a group of sleep disorders, obviously, involving sleep disruption that is primarily due to a mismatch between an individual's sleep-wake pattern and the pattern that is desired or required. So these can be caused by intrinsic factors, so being caused by the body. So there might be medical conditions and age-related sleep-wake shifts, as we know occurs in adolescence. It can also be caused by extrinsic factors, so caused by the environment, and examples of that are jet lag and shift work. What these all lead to is insomnia and severe sleep deprivation. So realistically, it's really important that you know the effects of severe sleep deprivation. If we have a look over at this little graph, we can see that the nighttime effects might be difficulty falling asleep at the required time, difficulty maintaining sleep, and waking frequently. The daytime effects are things like excessive tiredness and desire to sleep, lethargy, difficulty following schedules, and difficulty learning and accessing memory, mood swings, so on and so forth. Generally just your sleep deprivation characteristics. So unfortunately for you guys as adolescents, the time around puberty is generally associated with the onset of a characteristic pattern of sleep problems. There are two things that tends to happen for adolescents, and I mean overall we're suggesting that your sleep-wake pattern shifts forwards towards the evening, and so you go to bed later, so there's a phase delay, and you want to sleep in the morning. The reason that occurs is because there's one, the delayed sleep onset, so there's up to a 2-hour shift in the evening. So you feel tired later, therefore you go to sleep 2 hours later and you want to wake up 2 hours later, but you often can't because you have to go to school. Adolescents also need more sleep than adults, so rather than having about 8 hours as an adult, adolescents actually need about 9 to 10 hours. There are two reasons for this. And I'm going to address the biological causes first, and that's generally the easiest one to talk about. Now, we know that melatonin is a hormone that induces sleep. And we know that when it is secreted, you feel tired and then you go to bed. In adolescence, its secretion is actually delayed up to 2 hours. And so what that means is that melatonin is secreted up to 2 hours later. It means that you feel tired later and you go to bed later. Now, of course, if you were to have the 8 hours of sleep that everybody suggests you have, you still actually wouldn't be able to have the required amount of time because you want to wake up 2 hours later than adults. But added to that, you actually need to sleep longer, and so it's actually generally impossible for you to get the required amount of sleep that you need because you have to get up for school. Another factor that contributes to this, I suppose, shift in your sleep-wake cycle is social causes. So you might stay up later than you should because you have homework demands. You might stay up later because you're talking to friends or you're going to parties or you're socializing. And another simple reason is you might just be in bed scrolling through your phone. Now, as we know, the blue light emitted from your devices is actually enough to stop the secretion of melatonin. So again, you actually tend to feel more awake. Now, what happens after this is like a I guess like it's a cause and effect relationship. So you go to bed later, you want to wake up later but you can't, you have to go to school. And so at school you're really tired, at home you're really tired, and you will never catch up. And so what happens is you are generally really chronically sleep deprived, which is not super good for you, obviously. So a really good graph to look at is this one here. So you go later to bedtime due to later melatonin release. You must wake up normal times, so you accumulate that sleep debt, which I've talked about before. Now, if you have a higher sleep debt, it means the more sleep deprived you are, and obviously you have more effects. You're sleep deprived during the week, and that continues, and then on the weekends or on the holidays, you actually sleep in, and what that actually will continue to do is it actually continues or reinforces that disruption. So because you sleep in, you want to go to bed later. So for example, I actually do this on the weekend as well. When I'm working very hard, like an exam period, I'll go to bed quite late because I have to get up for work. I just continue to be sleep deprived. And then on the weekends, I'll like sleep in or I'll have a nap, and that will just mean that I'll actually go to bed later than when I should, which means I wake up later, and that just continues the cycle. So it's obviously it's pretty maladaptive. What this chronic sleep debt in adolescence does is it negatively affects various aspects of their lives. And you have all of these effects here. Look, pretty much like it's just the effects of sleep deprivation, okay? But it's good for you to know, it was actually essential for you to know what the two shifts in patterns are. So they're shifting forward towards the evening, and you need more sleep, and why that might be. So the biological causes and the social causes. Okay, so jet lag. Jet lag is a temporary extrinsic circadian phase disorder characterized by fatigue and sleep disturbances that result from a disruption of the body's normal circadian rhythm following long periods of air travel through several time zones in one day. That is a big mouthful. Why does this happen? So pretty much like shifting to a new time zone results in a mismatch between our internal circadian biological clock and the external environment, okay? So pretty much the environmental cues do not match our internal body clock. So what is actually happening is our body clock is out of sync. What this feels like is our body feels like it's time to go to sleep when others are having breakfast or it's the middle of the afternoon, or we feel wide awake when it's late at night and everyone else is in bed. Because travel tends to be quick, particularly via airplane, our sleep-wake cycle remains aligned to the environmental time cues of the home time, because there hasn't actually been enough time to adjust to the new time cues. This desynchronization is quite temporary, but the brain and the body needs to adjust to the new environmental conditions, which includes resetting the sleep-wake cycle. So in the interim or in between, before our new sleep-wake cycle has been set, we actually experience a fair few effects of jet lag. And so those effects tend to be both physical and psychological. So they may leave us with sleep problems, feeling unwell, and having more difficulty functioning than normal. We might have difficulties in initiating or maintaining sleep, particularly when we're trying to sleep and it's out of sync with our home time, excessive sleepiness when the biological clock is set to sleep, reduction of daytime alertness, greater number of arousals in comparison to home-based sleep, greater percentage of NREM1 during the first 2 or 3 sleep episodes when you arrive to your new destination. And also other circadian rhythms could also be disturbed, so things like hunger, eating, hormone regulation, body temperature, and that kind of stuff. The severity and the duration of jet lag depends on the number of time zones crossed. The direction of travel, so they say west is best, and I'll explain that in a moment. The duration and the quality of the flight. So why is traveling east worse for jet lag? So rapid long distance jet travel in an easterly direction, which is like over multiple time zones, does not follow the apparent pathway of the sun. And so therefore it's actually counter to the environmental day-night cycle. So what actually happens is there's actually a greater mismatch between the circadian sleep-wake cycle and the day-night cycle of the external environment. Because the circadian sleep-wake cycle is naturally longer, just over 24 hours, shortening the day by travelling east is actually much more disruptive. Easterly travel runs counter to the cycle's natural tendency to drift towards a 25 hours and lengthens the day. So the westerly direction occurs in accordance with our body's natural tendencies towards a 25-hour day. So pretty much what you're wanting is to travel west because it is a slightly longer phase delay, which is in tune with your natural circadian rhythm. However, if you fly east, it's actually a naturally shorter phase delay, which kind of screws with your clock because we typically run towards like a 25. It's actually like 24.2, but let's say a 25 hour circadian rhythm cycle. Sorry, it's very late and I'm getting very tired myself. So I'm nearly done though. Typically, disturbances can reduce after 2 to 3 days at the destination, and we can fully adapt about 8 days. More specifically, our internal body clock, it really just takes a few days. Temperature and hormonal rhythms are about a week though. Okay, so this is probably about the stage in the PowerPoint. Actually, honestly, I was probably there like 3 slides ago where I tend not to make that much sense, so I apologize. It's like 11 o'clock at night, so just bear with it and you can ask me questions in class if you are confused. So the last one that we're looking at is another external circadian phase disorder, and you have to keep in mind that, as we know, humans are not nocturnal. They are programmed to be active and alert during the day. Shift work kind of really screws with this. What it involves is hours of paid employment that are outside the period of normal waking day and often involve rotating schedules, so extrinsic sleep phase disorder. If you've ever known a shift worker, or if one of your parents is a shift worker, you might know that there tend to be 3 traditional shifts of the day. So you tend to have like a day shift, an afternoon, and a night shift. They can be fixed, so the same shift pattern, or they can be rotating. Shift work is pretty common for policemen, paramedics, firefighters, doctors, nurses, pilots, and all sorts of people. So my dad's a firefighter, so he's a shift worker. So his rotation is like he does 4 days, then he does 4 nights, and then he has, no, wait, that's not right. I think it's 2 days, 2 nights, then he has 4 days off. And he always says that like he can do days, they're completely fine because obviously he's awake and aware during the day. But when he does nights, he always comes home and he's really, really tired. And often after he does a night shift, he tends to have to have a nap. Luckily, the mothers sleep a lot. And it doesn't actually matter how much sleep we have, we can always go back to bed at the normal time. So he's actually pretty unaffected by it, but he does get quite tired after a night shift. So those who have, or those who are shift workers, they tend to have several symptoms. They tend to be insomnia and excessive sleepiness. So when they want to go to bed, they can't go to bed. And then when they are awake at work, they probably have excessive sleepiness. There's a decline in their mental state, so they might have an increased risk of depression, anxiety, and physical functioning, heart problems, ulcers, things like that. They also have heightened risks of having accidents or making a workplace error in the early hours of the morning when melatonin secretion is generally at its highest, and they should be asleep. So why does this occur? Of course, the night shift disruptions are mainly caused by external environmental factors, so those Zeitgebers. And so shift work normally disrupts as normal circadian rhythms because, of course, shift workers tend to be awake when melatonin is high and they should be asleep and vice versa. Because they tend to be awake when melatonin is high and they should be asleep, and they want to sleep when their melatonin is low, so they should be awake, they tend to actually have 2 hours sleep on average than workers who just work during the day. And of course, what occurs then is they tend to have chronic sleep deprivation. And again, like all of these circadian phase disorders, you tend to have those sleep deprivation effects. Also, I'm super sorry about these headings. They're really annoying, but it's just the transition between my Mac and the PC, so apologies. We're nearly there in terms of content, so that's a good thing. So the treatment for circadian phase disorders, not so much sleepwalking. There's no real cure for that or treatment for that because we don't even know really what causes it. But anyway, so the treatment for circadian phase disorders is bright light therapy. So bright light therapy or phototherapy involves timed exposure to the eyes, and it's to intense but safe amounts of light. Now that can be either natural light or it can be artificial. Tends to be artificial. So what's commonly used is a light box, and you can see images of light boxes to the right. But it's commonly used, the light box is commonly used, and patients don't generally look towards the light directly, but they are positioned so the light can still hit their eyes. Sessions last about 30 minutes to 2 hours, although 2 hours is like a super long time to just be like hanging out near a box. So I guess it depends on what you're doing in your day. It's essential to use the light at the right time of the day, and pretty much what the light does is it stops the secretion of melatonin. And it kind of resets the sleep-wake cycle. And so when you do it, what you're doing is you're just bit by bit gradually shifting someone's sleep-wake cycle to a more appropriate schedule. The problem is though, what can actually happen is it can actually cause headaches, eye strain, or nausea if used incorrectly. It is really important to use it correctly, and so the light must be used at the right intensity. It's really important to use it at the required time because you can't really just shift your sleep-wake cycle just all around just for funsies. And you have to use it for the right amount of time to actually stop the secretion of melatonin, so on and so forth. So just a heads up, this would be a great connection with the suprachiasmatic nucleus. And I can imagine, actually, yeah, I can imagine there'd be some really good extended responses and questions that you could ask about light therapy and the SCN. I'm quite sure in last year's trial papers that we gave the kids, there were tons of questions on this stuff. So you'll have lots of practice. So here is a little, I guess, table is what it is, of the 3 types of circadian phase disorders, how their phase shift is desynchronized, and the timing of the light exposure to actually shift the sleep-wake cycle back to normal. So we have delayed sleep phase disorder, which is obviously the change in the sleep-wake cycle in adolescence. So what this means is that the sleep-wake cycle is shifted forward. That always really confuses me. What I normally say is there's a later sleep onset and therefore there's a later waking time. So what happens is the person is exposed to light in the early morning in between 6 to 8 a.m. to help advance the circadian rhythm to an early time. Okay, so what's actually happening is we want that melatonin to be secreted earlier, so they can actually get up on time. So they feel awake at 8 o'clock when they're meant to get up and whatever. In terms of our shift work disorder, so this is when they are generally working when melatonin is high, so when it's night, so they feel drowsy, and they are trying to sleep when melatonin levels are low, so they feel more alert. So for shift workers, particularly night ones, late evening light therapy towards the beginning of the shift is helpful because what that does is it inhibits melatonin secretion and therefore sleepiness. So when they are working, they actually feel more alert. In terms of the time zone change syndrome, or jet lag, the sleep-wake cycle remains aligned to the environmental time cues of the home time because there actually hasn't been enough time for the sleep-wake cycle to adjust. So this really depends on like if they're traveling east or west. So if they're traveling east, the sleep-wake cycle should be advanced, so light exposure in the morning at the destination. When traveling west, the sleep-wake cycle should be delayed, so the light exposure in the evening at the destination. And what that will help to do is resynchronize the sleep-wake cycle to the new home time, if that makes sense. So they are the disorders and they are how to treat them. A lot of this is like just the content. So unfortunately, it's like those risk factors with mental illness in so much as you just need to know the content, okay? What I would suggest you do is just make a big freaking mind map, and that will probably help you to kind of figure out how everything connects. After you have watched the Explain Everything written in the notes, I'd like you to do booklets activities 14, 15 and 16, and they will help you just to consolidate what you've learned in this Explain Everything. When we go to class, I'll check these for you and I will send you the answers so you can actually just double check that you have everything right. But I really do need you guys to do this homework for me, and I need you to do it properly. So when we get into class, I can consolidate with you and we have enough time to do hot questions and things like that, okay? This content isn't very hard, but it is a bit finicky in terms of the wording, and I would hate for you to make silly mistakes in your very last SAT.